Okay, so hello everybody. Welcome to the third masterclass in managing asthma in children and young people as part of our Asthma Updated Guidelines series in collaboration with Asthma and Lung UK. My name is Preeti Minhas and I'm the Director of Clinical Development at Education for Health. So just before we proceed into the contents of today's webinar, a little bit about who we are. So we are Education for Health. We are a charity and our predominant aim is to support healthcare professionals on the front line with the knowledge and know-how to improve positive patient outcomes for those living with long-term conditions. We regularly engage with about 27,000 healthcare professionals from across the UK, both from primary and secondary and tertiary care. So to support us, we have a team of clinical associates from across the UK who have frontline experience. And we also have our clinical practice advisory group who are made up of consultants and professors and clinicians to make sure we are looking at what's happening in the healthcare field and making sure that all of our clinical content is aligned to current needs and also future needs. At Education for Health, we have two main arms to the organisation. One arm of the organisation is where we deliver academically accredited courses in collaboration with the University of Hertfordshire at degree, diploma and master's level. And we also deliver short, sharp pieces of bite-sized learning, as we are today to support you in your roles. So that's a little bit of an introduction around who we are. And today, like I said, I'm really delighted to be working with Asthma and Lung UK to really support you, to bring you the information that you need to support your patients with asthma. And I'm delighted to be joined by Dr. Ian Sinha, who will take you through the contents of today's presentation. Welcome, Ian.
Right, thank you very much. I think I've now taken control of the slides.
Yes.
Excellent. Yeah. So, hello everybody, and thank you for the invitation to join you today. So, I'm a respiratory paediatrician at Alderhay Children's Hospital in Liverpool, and an honorary professor at the University of Liverpool, of professor of paediatrics. I know this NICE guideline very well because I wrote the paediatric bits of it in conjunction with the team, and I think it's a really it's a document that we're very proud of. It's a guideline that we're very proud of, and the levels of expertise at NICE and BTS and SIGN that all contributed to this was really amazing to see. We're very lucky in this country, I think, to have NICE, and people around the world are often quite jealous. And having been part of that process, I can attest to how robust the process of writing this guideline is. I understand that the diagnosis had been covered in a different masterclass. That's also a fairly radical change that we made in some ways. And I think the management is a big change as well compared to what we've been used to. There's certainly been a need to improve outcomes for children and young people with asthma for some time. Part of the difficulties that we've had over the previous years is that we've had various guidelines from which we can choose. So there had been the BTS SIGN guidelines, and there was a NICE guidance, and obviously overarching globally is the GINA approach, and so we needed a consistent approach to this. I think whenever we talk about the NICE guideline, and people don't always understand what goes into it. The guideline and the guidance and the recommendations that were made have been evidence-based where possible, but there's also a group of clinical experts and pharmacists and other people on hand to try and contextualize that evidence. And so it was important to us to try and get what we thought was the most evidence-based approach, but it was also important to us to focus on an approach that's quite person-centered and enables people to tailor their treatment based on what we know. Before I go on, by the way, I think thank you to Education for Health for providing these slides. By the way, I should have acknowledged that. And the reason that I'm here presenting on behalf of Asthma and Lung UK is that I'm a member of their Council of Health Professionals. So in terms of the person-centeredness, I think one thing was that the management of asthma, actually, when it comes down to it, can be pretty simple. So we did want to simplify the diagnosis, and we wanted to simplify the treatment. We've known for several years that SABA only use is associated with bad outcomes, including death. So the key thing for all of this was, how do we bring steroids, inhaled steroids, into people's lives? We wanted some clarity around that, and we wanted to just make it easier for people to get their head around how they can use steroids with their asthma, but also emphasize that salbutamol is not a treatment for asthma. It's a reliever, it's a rescue, and that the key mainstay of treatment is inhaled steroids. And as we come on to, the regimes that we have for doing that are different to what they used to be. So let's start with the 12-year-olds. Adolescence is a really important time in a person's life. It's a time of biological and sort of social and psychological cognitive development that happens at a very rapid phase. So adolescents aren't young children, they're young people, but they're not quite adults, so they're a unique group. We felt from the outset that the diagnosis of asthma in adolescents was more akin to that of children, whereas the treatment of adolescents would be more akin to what we promoted in adults. So they're a funny group in that regard. I think one of the key things that we also recognise is that there is a group of deaths that happen in adolescence with asthma, and it was a particular group that we wanted to focus on, inhaled steroids. And for this group, the key thing really is ICS and LABA together, and there's now good evidence that this is a good approach. So the options that we have for 12 and above adolescents is basically, we're trying to avoid SABA like the adult pathway. We're trying to avoid SABA monotherapy, which is what these guys quite often take, even if they're prescribed inhaled steroids. The thing that they carry around with them is a blue inhaler. It's important to think about licensing and things, and we'll come on to that later, but you'll actually have your own local and regional approaches to this, so I won't dwell on that too much. But the key thing really is the idea that these guys shouldn't be given SABA only, and they should be told that inhaled steroids are important for them. Like I say, we'll come on to the licensing and marketing information in later slides. But the two key approaches that are different to what we've said in the past of the fixed dose regime is anti-inflammatory reliever therapy and maintenance and reliever therapy. So air and MART. Let's move on to these. So air therapy is, in essence, instead of saying to someone, here's a blue inhaler, here's a steroid inhaler, what we're saying is, here's an inhaler that's got both a reliever and a steroid in it. The evidence, largely from studies in the US, suggests that for people with mild asthma or newly diagnosed asthma, this is a better approach than just giving them a SABA. Right. What we don't know really in younger children, but we've got a bit of a feel for in adolescents included in adult studies, is that this significantly reduces the dose of steroid, the cumulative dose of steroid that someone takes over the course of the year. And so in essence, what we're saying is, use this as your only inhaler, but use it in a symptom driven way. Okay, so we're taking away the fixed dose and just saying, when you're symptomatic, take it. When you're not symptomatic, don't take it. For younger children, and to a degree with adolescents, this is still a sort of research recommendation that came out of the process, and we're currently conducting a randomized controlled trial in primary care of daily versus intermittent steroids for children with mild asthma. This is an NIHR funded trial called Asymptomatic, and we might end up in a situation where this gives us a bit more information. But for now, we're saying that air therapy for adolescents is a reasonable thing to do. But if they are presenting with quite severe symptoms or severe exacerbations, it probably makes sense to skip that step and give them a trial of MART regime. In other words, having routine steroids. Again, and I can't come back to this enough, that if there's a group of people who, for whatever reason, don't take to air therapy or don't take to MART therapy, and therefore have to be on a regular thing, then that's okay. That's a thing. It might suit some people, but the key thing that we need to be saying to people is that salbutamol is not a treatment for asthma. It's a rescue treatment when things are going wrong, and you need to have regular inhaled steroids. There's a case that's here that can I'm sure is something that many of you can relate to. So this is a 14-year-old lad who's got asthma, has got diagnostic tests, in particular FeNO is a useful test, and I won't revisit the diagnosis of asthma here, but the key thing is that all of this pathway starts from a good history and a good clinical approach to deciding whether someone's got asthma. So on here it says diagnosis suspected asthma. Actually, that FeNO of 42 would be would support a diagnosis of asthma. So we would say that he's got asthma, and that we would start him on air therapy according to the guidance. I won't go into the action plans in a lot of detail, but I would signpost you to the Asthma and Lung UK resources, which are excellent, really, really excellent. And one of the key things about self-management is knowing how to manage your asthma on a good day, on a bad day, and when you're having a very bad day and you're having an asthma attack. So I won't go into those things in detail here, but if you haven't come across the Asthma and Lung UK resources, please do take a look. So where does that leave him on here? So we've got a newly this is the algorithm. As someone who hasn't really got a skill in drawing boxes and arrows, I'm grateful to the nice team for putting these together, because I just kept struggling to know which way things went. So, but I think the algorithms are really helpful. And what we've said here is that he's this lad Finn. We would start him on air therapy, which is the green box just after we've said he's got a new diagnosis. So let's say that we then review him, and he's been on air for the last 6 months, and it started off all right and he was quite happy with things, but actually over the last couple of months his asthma seems to be giving him more trouble with regards symptoms, and these are often the symptoms you might see: increased coughing that might make him wake up. His FeNO's 30, his asthma control test is reduced. So this implies that his asthma is poorly controlled or suboptimally controlled. Interestingly, and one point that we would make is that even though we've done his FeNO there today, that's not a mandatory thing in the pathway. It's something that we're suggesting that people might want to do if they want to get a feel for why someone's asthma is poorly controlled, etc. But the key thing is that he's telling you that he's symptomatic and you've got a diagnosis of asthma. So the next thing that we would move on to would be MART regime, and that would be something that we would use in someone who's not controlled on air therapy or not controlled on fixed dose with ICS and SABA and separate inhalers, and we would start on a lower dose of the MART treatment. Again, I'm not going to go into this in a lot of detail, but please do take a look at the really excellent MART asthma plan that has been prepared by Asthma and Lung UK. You'll be able to find it on their website, and certainly many people in your practice or wherever you work in secondary care would be able to get a hold of this for you. Our feedback from people with asthma is that they find it useful as well. It's well put together, but I think the key thing is that people need to have it. They need to know what to do. You need to write it down and explain to them. And in essence, the gist of it is, and this varies between inhalers and what people want and stuff, but in essence, you're talking about one puff or two puffs twice a day, and depending on the inhaler and the dose regimens, up to 4 doses in between. People are often worried about what do we do with the salbutamol in people that we're putting on MART treatment or even on air treatment. What about people that need the salbutamol? And I think the pragmatic answer to that is nobody needs their salbutamol. They may be wedded to their salbutamol, but salbutamol itself is, it's a drug that can give you symptomatic relief, but it doesn't get to the root of the problem. So I heard someone say in a webinar once, which I've absolutely nicked this phrase and I'm using it a lot in clinic, is that if you were to say to a patient, I'd like to upgrade your iPhone from an iPhone, I don't even know the numbers these days, iPhone 7 to an iPhone 15 for free, they'd say, yeah, they would see that as an upgrade. And we should have a similar approach with reliever therapy in asthma, that what we're actually suggesting here, and the evidence supports this, is that using an ICS LABA is an upgrade on using a SABA. Okay, so there, for me now, is no real place for people having SABA if they're on ICS LABA. The next question that often comes up, and it's certainly something that we've seen in our practice, more so for younger teenagers, but also anyone who's got dysfunctional breathing or any other reason why they can't take a big breath out of a dry powder inhaler. The question is, well, what should they do when they're having an asthma attack if you take away their SABA, because they can't breathe when they're breathless? And we discussed this, and probably one of the wisest things that someone said in the NICE process was one of my adult colleagues, Professor Fowler from Manchester, who was the adult lead and I was the pediatric lead, and he said, why would you give some, and we all know this, we all know that you shouldn't give people 2 inhaler devices if you can help it. Just one device that someone knows how to use well is better than 2 devices. And we all kind of agreed with what he said. He said, why would you give someone a device that's not their usual device to use at the time when they're most vulnerable and most breathless? And so the outcome of that was that if someone really can't use their DPI when they're breathless or having an asthma attack, one option you've got is to put them on MART through a different device like an MDI, or another option you've got is to say, right, well then they're not ready for it. The point being that when someone's having an asthma attack, they shouldn't be taking an inhaler off the bench. They should be using like off the substitutes bench. They should be using an inhaler that's in a device that they know how to use. Okay, so if we work through this again with this young lad, so we've now started him on MART, which is the yellow box on the right. We would probably start him on a low dose of MART. We'll come on to what that means, or I'll certainly show you a table. And again, what you might find is that he has some response to this, but if you review him, which you should, because you should review people after making a change to their treatment, sounds like a really obvious thing to say, but it's something that doesn't actually happen as much as it probably needs to. And again, you might well find that we need to go up on his treatment. At each of these steps, you'll have seen that we'll have said, check the inhaler technique, check his adherence, check exposures to triggers and things like poor housing and other stuff that can trigger asthma, which is all listed in the guideline and which you know anyway. But at this point, if you've got the basics right and he's still symptomatic, then it's time to think about a slightly different approach. If they are, if he or other adolescents are not well controlled, despite good adherence, then you may want to check a FeNO level. You may want to check his eosinophil count, and you might at this point be saying, well, he's just got bad eosinophilic asthma. You might find that actually those are okay, and even if they're not, you might think that it might be worth starting a leukotriene receptor antagonist or a LAMA, long-acting muscarinic antagonist. This has found its way into the guideline at the stage where we're thinking about moderate dose MART regime. And so you would you would carry on working through that guideline, and that kind of takes you right down to the bottom. And it's at sort of this kind of stage that you might want to be thinking about referring on to your colleagues in secondary care if you're in primary care, and in secondary care thinking about these types of treatments. Tiotropium is something, or LAMAs are something that have been used for adult respiratory diseases. We've been using them in adolescents with asthma, with some benefit, but bringing them in to kind of check their inhaler technique with it becomes important, because it's a slightly faffy inhaler. But we've had some children who benefit, and the evidence suggests that it can be a useful thing to add in for adolescents. I'll be quite interested to see how that plays out. I personally wouldn't have a problem with somebody doing that in primary care, but I suspect in some places that varies a little bit. And I think one of the key things that we need to take from this guideline is that there's probably quite a lot of stuff in here that acts as a vehicle to develop stronger links in that interface between primary and secondary care, where we know that quite a lot of the action actually happens. So I personally am hoping that this guideline is we weren't aiming for something radical, we were aiming for something good. Turns out it is quite new and quite radical in many ways, and sometimes when that happens, it's a really good opportunity to pull services together so we can wrap things around what children and family need. So what is this? What does the evidence tell us about the approach? Well, the dose of inhaled steroid over the course of a year might be about 20% of what it would be on a fixed dose regime, so better ICS doses. The evidence is clear that this is a better approach than SABA only, and is an easier approach than fixed dose ICS in one inhaler plus or minus LABA and SABA in another. That's better asthma control and reduced exacerbations. It is convenient, patients like it, and it's simple. And it's a bit easier to step up and step down. I'll be honest, it's a bit trickier to know when to stop, but that's something that we'll pick up in around 4 years when people have been on this and we'll refresh the guidelines or whatever. I don't know, but by the time you're thinking about stopping treatment, it's usually a pretty low risk thing to do as long as you've got everything right. There is something around how you transfer people from other pathways. I guess the key thing to say in all of this is that if you have a one size fits all, it never quite works. There'll be some people who are quite happy with what they're on, and if they've got well controlled asthma, there's an argument to say, well, don't rock the boat. Focus on people with less well controlled asthma. But what we would say is that if anyone's on SABA only, it should be a priority to not have them on SABA only. Just switch them to air. It's an improvement. It's a upgrade on what they've got, and it's better for them. So that would be one thing. And I think considering changing to low dose MART would be in people who've not got well controlled asthma on one of the more traditional fixed dose regimes with a separate SABA. It would be worth calling them in for a review and talking them through the MART regime. When would you step up? I think if they're on low dose MART, or if they've got regular sort of ICS LABA and supplementary treatment, or if they're on a slightly moderate to higher dose of ICS, that would be a reasonable time to switch over to MART. To put that in context, we in our, albeit potentially this is a different group to what you see, but in our difficult asthma, I've been using MART in severe asthma or uncontrolled asthma in teenagers as my default. Now, by the time adolescents are coming to me by 12 years of age, if they've got uncontrolled asthma, and I've gone through everything, it's been about 2014 when I made that switch. And what we found in our difficult asthma clinic is that 75% of adolescents who were referred for a biologic therapy, basically, or for multidisciplinary input with a view to potential biologic therapy, 75% of them get better if you put them on MART. And the sort of insight that I have found quite good, which I always tell people, is explaining why MART is beneficial for them, not in terms of evidence, in terms of p-values and risk reduction things, but this is the exact spiel we give to adolescents who are on fixed dose who come to us. We say that the most important treatment that you have in your inhaler is an inhaled steroid, and being on a MART regime enables you to tailor the dose of that steroid on how you are. So it empowers you, and it also makes us know that you have inhaled steroids in your life, in your system, going into your airways. And we reiterate that that is the treatment for asthma, not the reliever. We also reassure them and we say, look, I know you get a feeling that the SABA helps. People often describe that. They say, well, I like the salbutamol because I can feel it opening up my airways. And what we always say is, if you are feeling a response to that, it's because your asthma is not controlled. You're getting symptoms because your asthma is not controlled, and we can likely get on top of that this way. So adolescents are up for the switch. It's an easier thing to carry around a DPI than it is to carry around an inhaler and spacer, but around 1 in 5, I think at the last time we looked, around 1 in 5 adolescents prefers to have an MDI rather than a dry powder inhaler, and we go off license and we give them MDI, beclomethasone formoterol as MART regime, and they benefit from it. People often say, how do they get discharged after being in hospital, where you treat them with SABA, if they've come in on MART and they end up on salbutamol? What do you send them home on if they haven't got a salbutamol inhaler? And we had a long discussion about this with various teams. One of the hats that I wear is that I'm the Northwest Paediatric Asthma Lead, and another hat that I wear is that I'm the National Lead for the National Respiratory Audit Programme for children and young people. And we had lots of discussions. What salbutamol should we tell people to take? And I thought, since 2014, this hasn't really come up because these kids just stop having asthma attacks. They just stop. They just get loads better. So it is something that we're going to have to sort of figure out as we go along, and there will be things that happen. But in the main, switching to MART regime is a good thing to do. And certainly by that time, you'll be thinking of sending them in for a review with us. I won't go through each line on this, but again, as with most asthma guidelines over the years, we've got a table talking about low dose, moderate dose, and high dose, and I think you will have access to these slides. So that is a useful table for reference. And then we move younger, and the younger you go with asthma, the more difficult it is to treat because the less evidence there is that's available. We didn't recommend at this stage, which is a potentially, it's a bit of a shame, but we haven't recommended air therapy, and people have asked why. When we have recommended MART therapy, when there are licensing issues in teenagers, etc., and in younger children. But there just isn't the evidence yet for air therapy in that group, and we're hoping that our asymptomatic study does help to identify that question. But this age group of children is different to adolescents, and it's different to adults, and they should be more responsive, in my opinion, which is why we're doing the study. They should be more responsive to regular inhaled steroids, and they could potentially be less responsive to intermittent use of inhaled steroids. So that's why we're doing the study, but that might be something that changes over time. So what we're suggesting in this group is that when these kids are first diagnosed, put them on a low dose ICS with a SABA as needed. Again, the key being that nobody should be given just a SABA to see whether it works or not. You put them on an ICS and the SABA. That's better than using SABA alone, and people worry about side effects, but actually at this sort of dose, in this sort of age range, the sorts of doses we're doing shouldn't be associated with very severe or problematic side effects. There are a group of children, and this is separate, this is not something we looked at in NICE, but there's a group of children who do get side effects from steroids, particularly adrenal insufficiency, but that seems to be an idiosyncratic thing. It doesn't seem linked necessarily to the type or the dose of steroid that they're on. Obviously that has a bearing, but it's difficult to pick. But what we would say is, if people are on inhaled steroids and you are reviewing them, do ask about side effects. Probably the key one I ask about, and certainly in our group we ask about, is levels of energy, and that's because being on inhaled steroids can have adrenal suppressive effects. But generally speaking, we don't think that the risks undermine the need to use them in children with asthma at this age. If that doesn't work, then there are two options we have. One option is to put them on a low dose MART regimen. This is newer for us. We have traditionally in our clinic and in other places have used MART for adolescents, but the evidence is there that MART regime works in these sort of primary school age children as well. Currently, that's based on the use of a dry powder inhaler, but as we highlight later, there are other options. And so more often than not, maybe not more often than not, I don't know the exact numbers, but there's a group of primary schoolers who can do a dry powder inhaler. There's a group of primary schoolers who can't. And in that group, so in the group who can do dry powder inhaler, it would make sense to give them a trial of MART. In the group that can't do the dry powder inhaler, then there comes a question of whether you just increase the dose of inhaled steroids in their fixed regime, or do you put them on an MDI or other type of MART process. So this is something that causes a lot of confusion. I'll get to the gist of it on, I think, the next slide or the slide after. But in essence, there's a marketing authorization or product license, and that tells you which patients you can use things in. And if you use them in other people, that's called off license. And in terms of, off label. And in terms of asthma in children, generally speaking, that's either talking about the age at which we're using it as a different population, or it I've just given a thumbs up on my video there. So either it gives either it refers to a dose of the age that we're using it, or the dose that we're using it, or the route that we're using it, or the type of inhaler that we're using. Now the key thing is that if you've got a patient that you go off label with, then it's your responsibility to tell people that it's off label. But we in NICE have gone through the evidence. It is literally the most robust scientific examination of the available evidence, and we knew that this stuff was off license. It didn't actually impact on our decision making about whether it was clinically or cost effective. We knew that this stuff was off label. We knew this stuff was unlicensed, but this is what we felt, and we had people with asthma in our within the guideline writing group. We said people can make informed decisions about their care. That's autonomy. We wouldn't have recommended something off label if we thought that it was a frivolous thing to do. The things that we've said are things that we have said. The recommendations that we've made are based on our sort of reading of the evidence, that there is enough evidence and or experience, and actually in most situations both, to support that change. So alongside this thing about off-label, there's also a responsibility for healthcare professionals to follow relevant guidance. And alongside that, there's a responsibility of integrated care systems or primary care networks or secondary networks or whatever it might be to support that and enable that to happen. So it's important that we offer people evidence-based treatment, and that's more important really than whether it's licensed or off-label. These are decisions for pharmacy leads to make in conjunction with clinical leads about making drugs available, or derogating from that and saying, no, we are not going to use this. But it shouldn't be down to individual prescribers to weigh up the pros and cons of that. There needs to be a systemic approach to this. Some of that just needs to change in formularies. Some of it requires a bit of research. But the point being, if you have followed NICE guidance and are prescribing off-label treatment, that's an okay thing to do. I don't know if this is legally the right sentence to say, but what I mean is that, and I don't mean to say NICE will bear all the legal costs or anything, and that's not what I'm getting at. But what I'm saying is that because it has been through the NICE process, we are in a position to say we recommend the use of X drug, even though we know that it's off-label, and we've acknowledged what's off-label in the actual guidance. And this is another way of putting it here. If you look at the prescriber responsibility, I think this is a nice slide. And again, thank you to Education for Health for putting these slides together. If you if you're looking at off-label and unlicensed use, there are situations where this might be in the best interests of the patient, and if you adhere to the prescribing policies of your institutions, your employers, and if you are able to understand that this has come from a NICE process, then things are okay. So there is some logistical work to do about off-label and unlicensed treatment, but you're going to get kids like this all the time. This lad here, Henry, looks like he's played a bit of football. He's had diagnosis of asthma since 6 years of age. Quite an atopic sounding kid, and he's also got severe he's got allergies to nuts and sesame seeds. So this is the kind of kid that you would worry about. But luckily, he's not had any acute asthma attacks. But despite being on Clenil and salbutamol, you find on the annual review that we hope people get that he gets wheezy when he's playing in the garden. He's coughing at night. His inhaler technique is really good. They try and avoid things, so you're avoiding all the problems, and so you've basically got a kid whose asthma should be better than it is. Well, what are the options that we've got? I think we would all agree that he's not got well-controlled asthma if he's symptomatic on exercise several times a week. You'll notice that his FeNO was quite low, and that's not uncommon in people who have been on steroids, which is why, again, I'm not going down a diagnosis route here, but this is why we really pushed, and I continue to push, that FeNO should be available in all practices, because it enables you to check their levels of inflammation before being on inhaled steroids. The fact that Henry's FeNO is only 14 either means that he hasn't got asthma, he's got really low asthma, or that his asthma is exquisitely responsive to inhaled steroids. Both of those are two very different things, and doing his FeNO when he's steroid naive is an important thing to do. That's an aside, but it's a really important aside because it reinforces the idea that all of this treatment pathway stems from a good clinical history and a strong diagnosis that's backed by objective tests. So now we're in a position where Henry's FeNO hasn't helped us one way or the other. His asthma is not well controlled though, so we could put him on a low dose MART if he seems able to do that. And then let's say that mum and him do want to try the low dose MART regime, and that might help his health, might help his confidence, whatever. And if we go through the idea with them that this is off label, but we also agree with them that getting better asthma control will be a useful thing to do, I can predict that for the vast majority of children, that last bullet point there is what you will see. You will be excited about the new inhaler that's selected. It takes a bit of time, but it is time well spent engaging with children about their inhaler choices. What could you do after that? Well, we do come on. There is a picture of the algorithm in a couple of slides' time. So if you start him on low dose MART and it doesn't quite hit the spot, you could increase that dose of MART. If you find that MART just doesn't suit him, then you could just step back to fixed dose regime and increase the dose. But there are options that we could add in as well. We haven't recommended in the NICE guidelines, although we have used this in tertiary centres, but we've not recommended tiotropium here. But we have said that you could offer leukotriene receptor antagonist, which I'll come on to in the next slide. So you can either go up on the MART, or you can go up on the ICS LABA fixed dose, or you can add in an additional therapy. And there is an algorithm that's got that all summed up. Here are two really key points: that we're really bad at stepping down treatment in children and young people and adults and everybody. We're really bad in this country at stepping down treatments for children with asthma. There's no real evidence for how to do that, and we're currently start embarking on some research around that. But when things are controlled, it's worth making a shared decision with families about stepping down. And again, and I can't say this enough times, if this talk was 60 slides of me saying do not give a SABA without giving an ICS, it would still be an hour well spent. Okay, so that's a really key, important part of this. I'm going to come on to montelukast in a bit, because it does come up. But these are this is the algorithm. It'll be up on the screen here, so you can either get it from here or from the NICE guidance itself. But this is in essence what we've done with that lad Harry, or maybe Henry. What we've said is offer twice daily low dose ICS, and if that doesn't work, then you can either go down a MART pathway, which is in the yellow boxes, or if they're unable to do a MART regime, then we stick to the more traditional approach that has been bread and butter to you for some time, of ICS LABA plus or minus an LTRA. The under fives, and this is coming towards the end of the talk as we move a bit younger. We're hampered by how difficult this group can be, but also we are in need of trying to address things in this group. It's a difficult group, but it's partly difficult because there's no objective tests for asthma that are routinely available. When we've looked at the evidence, both in NICE and previously when we've done this for our regional guidelines on preschool wheeze, when you look at the evidence, in essence, for under fives, there's three key questions. And it's not really a have they got asthma or not. It doesn't really fit in that. It probably does for some kids, it's quite obvious, but for other kids, it's kind of grey area. And so the three questions are: what are they like on a good day? Do they have severe and or frequent exacerbations, and is there any evidence of type 2 inflammation? And the more either on like an atopic history, or if you've got an eosinophil count, or an IgE or whatever. So the more of those questions that are yes, the more likely it is that it's asthma. The more that are no is that it's probably just a kid with a bit of viral wheeze. But in those where it looks like there are symptoms of presentation or severe acute episodes of difficulty breathing, it would be reasonable to give a trial of twice daily low dose ICS with a SABA as a reliever. And again, you'll see there that we've not said give a SABA on its own. We've said give a SABA and ICS. You may not be lost on you that this is the only place in the whole NICE guidance where trial of treatment is in there as a diagnostic sort of help almost, or something that you would try. A trial of treatment to see if they benefit from it or not. There is no real evidence for this anywhere for anybody, but it's something that's very widely done. However, in this group, we do worry about putting them on treatments that they don't need, and missing diagnoses. So giving them a trial of treatment and reviewing them becomes a really crucial bit. Again, if things aren't working, the default isn't to just increase treatment or refer in. There are things that you can do in practice that can help. You can check that they're taking their inhaler right. Make them show you. Don't get them to talk you through what they do. Make them show you. We put quite specifically in here for asking about environmental sources of their symptoms, particularly housing. Yeah, that's a slightly different talk, maybe for a different day. One of the clinics I do is a clean air clinic, where we see children from around the country who are trapped in substandard housing, and you find that when you fix that, their asthma or their wheeze or whatever just gets better. And also, always reviewing an alternative diagnosis is important here. So I would say if you've got a child who's under 5 at this step, who's not benefited or not improved with ICS SABA, you might well be thinking about referring them on. If their symptoms resolve when you review them after sort of 8 to 12 weeks, people have always said, where does that 8 to 12 weeks come from? And yeah, it's a little bit finger in the air. Like 4 weeks seems unfeasibly short. Nobody can get a follow up in primary care in 4 weeks in November. But more than 12 weeks seemed a bit long, so somewhere in the middle. But the point is, within 3 months, you should have called them in to see whether it's benefited them or not. So if they're better and they stay better, then great, you don't need to restart them on anything. But if they've had symptoms or exacerbations in the meantime, then you may need to just give them more treatment. And at that point, there's little point calling them back every couple of weeks to see if they've responded. Just put them on and say, well, they failed. Let's give them a year-long course and see where we're at. If it's uncontrolled, then we would think about leukotriene receptor antagonists. And again, we would be thinking, if that doesn't work, to refer people on. Sometimes we put these children on LABAs, sometimes we don't. Sometimes we're missing something else like cystic fibrosis or other potentially less severe but quite troublesome problems. Sometimes it's just about housing, and sometimes these kids are just wheezers, and sometimes it's really difficult to manage them. So it's always difficult for anyone who's got an under 5 with uncontrolled respiratory symptoms to know what to do, and it would make sense to pass them into a secondary care service to pick that up. Montelukast was a interesting topic of discussion. Montelukast came out in the late 90s, I think. Around the time I started as a paediatric junior doctor, we audited the side effects of Montelukast. This was about 2003. And we found that around 20 to 30% of children had really bad side effects from Montelukast. So actually, for the last 20 odd years, this is not a new thing, but it seems to be gaining a lot of interest in the news at the moment. We've published a couple of systematic reviews showing that the neuropsychiatric reactions that children get, which can manifest as behavioral difficulties and sleep disturbance, really important. It's very important to try and pick these things up. Older children can get suicidal ideations. They can get them anyway, but there is certainly a concern that Montelukast can make this worse. So asking about mood, asking about sleep, asking about behavior is important. Interestingly, I would suspect, and apologies if I'm wrong here, but our experiences, or anecdotally, we find that most people tell parents to give Montelukast at night time. And the very first thing that I do is I switch it to the morning, because what we find is that there is no evidence for it to be given at night time. It's just that the randomized controlled trials looking at Montelukast used a nighttime dosing strategy. So what we tend to say is give it in the morning, don't give it at night time. And what we find is that their adverse effects in terms of sleep can improve. So that's one important thing to bear in mind and consider. Right, here's the last algorithm, and I think this is actually my last slide. This is what we've just discussed about treatment of the under 5s. And we're saying that if we're going to give them a trial of treatment, put them on ICS, give them a trial off treatment when they're better, but if they restart having problems, then restart the drug. Consider a leukotriene receptor antagonist, but stop it if there are side effects, and stop it if it doesn't work. It's not a hugely effective drug, but it's cheap as chips, so it's actually quite a cost-effective thing to try. But it stops being cost effective if you know that it doesn't work and you still carry people on it. So I think that's one of the key things. So to sum all of that up in about 3 sentences, whichever age group you're looking at, nobody with asthma should not have an inhaled steroid, and apologies for the double negative there, but everybody with asthma should have an inhaled steroid as part of their medication regime. Before stepping up treatment, make sure they're using their inhaler properly and have got the basics right, like an asthma action plan. And again, I would sort of signpost you to Asthma and Lung UK to have those resources. And it's really important that all of this starts from a good diagnosis of asthma. So keep re-evaluating the diagnosis if you can, and work with your local teams to try and, in my head, one of the biggest game changers diagnostically is to ensure that all practices have access to pheno. You might find that things just move nicer when you've been able to do that. I'm going to pass back over to Preeti, and thank you all so much for your attention today. Thank you.
Well, thank you so much, Ian, for taking us through the contents of today's webinar. That was great. And I think what's really important is that you were able to give the why, particularly being part of that development of that guidelines, which I think is really important to our frontline healthcare professionals. I think, certainly some of the takeaways are, delivering person-centered care. So again, like you mentioned right at the beginning of the webinar, using analogies really helps. So again, using things of like the iPhone, where our patients are very much used to those real life examples to help them understand the why, because they're not from a healthcare professional background. And so, talking about randomized control trials is probably not going to be helpful, but certainly using those key analogies, things they can interact with in everyday life really helps. And certainly the evidence base, so the science behind some of these decisions that we see in the guidelines. I think for our audience today, we talked a little bit about off licensing. Again, when you're looking at prescribing, think about the evidence-based practice, look at the MHRA guidance around these aspects, but also remember when you're prescribing, to refer to key resources such as the Royal Pharmaceutical Prescribing Competency Framework as well. I think they're real resources which will help you as individuals support your patients to make informed decisions about their care. So that brings me to the end of today's webinar. I think in terms of a very key part of today's webinar was around the personalised asthma action plans. And that really leads us to the next webinar that we have got planned, which is all about empowering patients to live with their asthma effectively. And we'll be releasing dates of that shortly, again in collaboration with Asthma and Lung UK. So I'd like to take a thank you to all of you for listening to us today. A particular thank you for Ian and Asthma and Lung UK in supporting getting this key information out to you to support your patients with their conditions. So thank you everybody for listening.